Let's get started. Hi everyone, my name is Sean. I am with the Knowledge Mobilization Hub of the CTN Plus, and I'm joined today from the traditional unceded territory of the Coast Salish people in Vancouver. I welcome you to introduce yourself and say what you will in the chat. I'm excited to welcome everyone to this meeting about adapting community-based geospatial research for harm reduction and STBBI services. So for today's meeting, we'll hear from Heather, Megan, and Dr. Andrew Eaton about their research program in Regina, which has been partially supported by the CTN Plus, and about how we could adapt some of their work about community-based HIV and harm reduction services in medium-sized Canadian cities elsewhere. So I'll just do a round of introductions before we begin. So Heather House is a research assistant with the University of Regina who works in partnership with the AIDS programs of South Saskatchewan. So since 2018, she has been dedicated advocate for healthcare, harm reduction, and community-based support. Drawing on her lived experience, Heather has been actively involved with nonprofit organizations and has helped implement harm reduction initiatives that meet people where they are. She is deeply passionate about STBBI prevention, treatment, and improving access to care for all individuals. And Megan Rowe is a PhD student at Dalhousie and the lab manager for the Eaton Lab. In her role as lab manager, she oversees the Eaton Lab's ongoing research projects, coordinates research activities, and mentors team members. And finally, Dr. Eaton is an associate professor at the Jane Addams College of Social Work, University of Illinois in Chicago, an associate professor at the Factor Inwintosh Faculty of Social Work at the University of Toronto, and an adjunct professor at the Faculty of Social Work at the University of Regina. A practicing social worker for over a decade, Dr. Eaton has developed a robust practice-based research program to address complex comorbidities and improve health outcomes for people living with HIV, sexual and gender minorities, and people experiencing mental health and addiction crises. So the group will present for about 45 minutes, and then we'll lead a discussion about their work. And I'm looking forward to hearing more about this work and its potential. So welcome.
Thanks so much, Sean. Hi, everyone. Lovely to see some familiar faces, and also nice to meet some of you who I don't know. Thank you so much for coming to our internal CTN Plus webinar on our program of research of geospatial community-based pop-up HIV, STBBI prevention, and harm reduction. Today, we're going to talk through some research that we've been conducting in Regina since April 2021, but in earnest since the end of 2022. And that's been kind of multi-phase in nature, has one study that's completed and one that's ongoing, and I'll get into that in a little bit of time. I wanted to first acknowledge that this research and our work is conducted on Treaty 4 territory, which is the homeland of the Nihilwak, Anishinaabeg, Dakota, Lakota, and Nakota peoples, and the homeland of the Michif Métis Nation. And that we're very honored to work in partnership and harmony with Indigenous peoples on Treaty 4 territory, and are very cognizant of the harms that colonization has wrought and continues to cause in the lives of Indigenous peoples in Canada. Back to the title slide here. So we're presenting two implementation studies today, one of which was funded by SURE, the Saskatchewan Health Research Foundation, with in-kind support from CTN Plus. And the second is funded by CIHR and by SURE. And this is part of a long-standing research partnership between my lab and AIDS Program South Saskatchewan, APSS. APSS has Executive Director Shani Mary Varghese as kind of my partner in crime, and she and I sort of envisioned this presentation together and intended to present it together, but she was unavailable to present it. So I will do my best to summarize APSS's fantastic work. So APSS is a community-based HIV organization based in Regina, Saskatchewan, They operate an incredibly busy needle exchange program where they provide safe drug use equipment as well as education on safer drug use alongside a suite of HIV, hepatitis C, and STBBI prevention, education, and treatment initiatives. And from Sean's introduction, you heard a little bit about my lab. I have recently moved to the US, which is, it's a weird time to move to the US. But as a result, I am ineligible to be the nominated principal investigator on most Canadian grants, like CIHR grants and many provincial ones. So we thought an internal webinar to present this work that's been going pretty well in Regina for a few years would be timely and may also lead to some new research collaborations where I may be able to support as a co-PI or a co-investigator if some of you were interested in picking up some of these strategies or adapting some of these tools for other areas or cities across the country. And speaking of timeliness, so it's probably no surprise to us on the call, these kind of maps we're pretty familiar with, that Saskatchewan has had out of control annual rates of new HIV infections for over 15 years now. But it's starting to be the case that Saskatchewan's not so much of an outlier within Canada. It's becoming more of the case that Canada is an outlier within the G7, as Canada is now the only G7 nation with rising rates of new HIV infections on an annual basis. So for those of us who have seen this map over many years, we may well remember that, Ontario and Quebec used to be not as darkly red. We're seeing spikes there. Manitoba has now come up to be right on par with a rate of new infections with Saskatchewan. Alberta has seen increased incidence. And while rates remain comparatively low in the Atlantic regions, BC, and the territories, they're also higher than we saw even 5-6 years ago. So HIV is certainly re-emerging as a problem when we think about new infections nationwide, which suggests that new or creative strategies may be required to curb this latest outbreak of the epidemic. And so just a little bit more context on Saskatchewan. So Saskatchewan is unique within Canada in that it is the only province where a majority of its new HIV cases year over year are primarily linked to injection drug use, as opposed to the other provinces which have their primary mode of transmission be sexual behavior. That said, Saskatchewan is also relatively unique among the Canadian provinces without having sort of a larger urban center. Saskatchewan's two biggest cities, Regina and Saskatoon, are a couple 100,000 individuals apiece, which is markedly different even from Manitoba, where Winnipeg boasts over 1 million individuals as its population. So when you look at HIV incidence across the Canadian provinces, but you take out the cities of 1 million people or more, you do see similarities across the country, as we see in Saskatchewan, which is that HIV is primarily transmitted through injection drug use. And we're also seeing that syphilis and hepatitis C infections across the country have very high rates amongst people who use drugs. So some of it is sexual behavior and drug use tied together. But overall, we're seeing HIV, syphilis, and hepatitis C as syndemic for people who use drugs in Canada and certainly in Saskatchewan. And here I describe Regina as a medium-sized city. Canada has a unique conceptualization of defining its cities. A medium-sized city is one that's between 100,000 people and 1 million people, which is a vast range. But when I'm presenting today and talking about Regina, we're thinking about non-walkable cities in Canada, which may have fluctuating infrastructure of healthcare and support. So it may be similar to areas within Canada that are outside of the gigantic urban centers, but also that aren't rural or remote or very small cities. So as I mentioned, we're presenting two projects today. Both used real-time geographic information system mapping of discarded needles and syringes in public spaces to inform community-based intervention research. The first study is called Mapping Needles, Reducing Harm. With this one, we used community-based web app of needle reporting and collection to geolocate brief naloxone trainings in areas that appeared to be hotspots for injection drug use, to provide members of the public who may be often within those local areas with the tools that they would need to be a good Samaritan and potentially prevent an overdose from happening on their doorstep. We also, through this project, offered peer-led, so led by people with lived experience, drug use, support groups regarding harm reduction around people who wanted to make a change in drug use but didn't want to quit, at least not at the moment. So that's been completed. That study ran from 2023 to 2024. And then just in June of this year, we launched a second study called 3 Infections, 1 Fight, where we still use our maps of where we're collecting discarded needles and syringes, but the interventions we're geolocating have become more sophisticated. Now we have 2 tents. One tent offers private point of care testing, as well as phlebotomy for HIV, syphilis, and hepatitis C. We're able to offer first dose syphilis treatment on site, and we're able to link to care for all 3 disease conditions. And the second tent offers more public education on safer sex and safer drug use, with a specific focus on pre-exposure and post-exposure prophylaxis, as well as numerous resources that Heather will detail for you later on today. So the study that's been completed, Mapping Needles, Reducing Harm, was the first study where we used data derived from reportneedles.ca to geolocate interventions. What is reportneedles.ca? So in April 2021, APSS was identifying that there were large numbers of needles and syringes discarded in public spaces like parks or parking lots or outside community centers or outside malls in Regina. And they participated in a kind of like a hackathon for social good and developed this website called reportneedles.ca. That's very kind of elegant as well as very simple. So it's a kind of a ready-made tool. It allows anyone to report discarded needles and syringes anonymously, and it's designed to support public safety and harm reduction. How does it work? The website uses Google Maps to make it easy for users to enter the location where they're noticing needles on the ground. And it's able to be anonymous on the user end and relatively confidential on the back end. In other words, it's currently being used in 2 locations in Canada. Those 2 locations cannot see each other's needle data. We're able to gate it off in a manner that needle reports stay confidential to authorized users on the back end within a set area. And this data helps us identify hotspots for substance use services. Reportneedles.ca is, as I mentioned, only in use at the moment in 2 Canadian cities. And I think it could be in use in more cities. Conventionally, when a member of the public sees a needle on the ground, there's a few options that they have before them. The person could collect the needle or syringe themselves and discard of it. You know, many people take that action and that own initiative. They can get a sharps container from Shoppers Drug Mart. They can use tongs to collect the needle, and when they have a full sharps container, they can take it in to Shoppers for a swap. That's very common, or to the needle exchange. But for people who are not comfortable collecting that needle themselves, this is what we were seeing in Regina before we created the website. They might call like a 311 or equivalent, so city services, or they might call 911 or equivalent or emergency services. Regardless of whether the individual happens to call city services or emergency services, it normally gets dispatched to fire, or on occasion it gets dispatched to police, depending on the area in Canada and the resources available and the attitude of the dispatch operator on the other end of the line. And when fire or police collect those needles, well, they're able to collect them safely, but they're not able to do much more than that in terms of providing like healthcare services or public health, education, and information. And as we well know, there's certain areas of cities in Canada that kind of become marked or labeled by drug use and see an enhanced police presence as well as enhanced police surveillance. And this does not help people who use drugs. In fact, it probably causes them harm. So this website does circumvent police and fire services to an extent, although we have good working relationships with these emergency services in Regina. Police and fire don't seem to really want to be spending their time going out into the city, searching the ground for needles. So at least in Regina, they've been more than happy to enter in their own needle report if somebody does call in to our website. So we then are able to keep the needle data. We don't share it with emergency services. So it might reduce over-policing of marginalized communities. And it may give us, as a community-based harm reduction organization, good information on where to set up shop to offer HIV, STBBI prevention and harm reduction services that could actually help people who use drugs instead of further marginalizing or criminalizing. So the left is what the public sees when they log onto the site. So this is how Google Maps is underpinning the site. We've probably often entered our address into a bar just like this one. As you start typing, it will auto-generate your address. Then the user can upload a picture of the needle or syringe that they've noticed on the ground, as well as provide a description. That part is the only one that's required. And optionally, if they want, they could provide a name or an email and phone number, because when we go out and do needle pickups, sometimes it's not especially clear where the needle is. We may need to contact the user for more information, but they don't have to provide this. It is optional. And then on the right is what an organization would see. So if another organization were to pick up reportneedles.ca, this is the dashboard that they would see. It gives some real-time metrics on how many needle reports have translated into successful pickups and how many times the workers were not able to find the discarded needles, as well as for each needle report, gives the time and the description, and you could also filter for the other text boxes you see on the left, allowing for pretty efficient needle pickup. I know when Heather and other APSS staff go on a needle pickup and they're doing 3 or 4 reports, it's fairly easy to bring up the list and be able to kind of go one by one. So as I mentioned, APSS launched Report Needles because they saw a community need in April 2021. And then in November 2022, they reached out to me to see about doing some community-based research tied to the needle reporting tool. And so we've been working together for 3 years now, although the website has been in operation for 4.5. And in that time, we've picked up over 35,000 needles from over 600 reports on the app, which this is a city of 220,000. So it's a very large number of needles relative to city size. And as you can see, in the first 2 years of the program, That's the first two ones on the top here. We collected tens of thousands of needles. Year one, we had about 150 reports, most of which we were able to successfully pick up. In year two, we had over 220 reports, 217 were successful. In years 3 and 4 of the program, which you see on the bottom here, we're still getting a couple hundred reports per year. So the website remains popular and maybe slightly increasing in community knowledge. But the number of needles collected has reduced dramatically. So we're receiving the same number of reports, we're picking up way less needles. This may partly be due to the fact that in January 2024, the Saskatchewan government started to make what became a series of legislative decisions to limit the distribution and the exchange of safe drug supplies in Saskatchewan. Regina, Saskatchewan, APSS is the community-based not-for-profit needle exchange program. Used to be, you could get safe drug supplies from public health. The Saskatchewan government made it the case that public health initially had to give a 1-for-1, so a true exchange for needles, and that they could no longer give out pipes. Then for a period of time, banned all public health distribution of needles. They've recently designated needles as a weapon, and police can drum up people who use drugs on weapons charges in Regina. So a series of draconian policy decisions from the Saskatchewan government have limited the number of needles in Regina and the number of needles that people are using. And we are looking at if this might be contributing to more needle sharing or more needle reuse, which may cause other drug-related harms. And so we receive the needle reports, we collect the needles. And then how do we determine locations with the highest needle prevalence or so-called hotspots? So these needle report points are tagged with exact geographic coordinates. These points are mapped and analyzed to see where needles are showing up most often. And then we're able to use analytic tools specific to geographic information systems to highlight areas with many reports and show where services may be missing. So here are some maps that one of my doctoral students has generated. This shows you the location of reported needles in Regina over the full period of app usage up until 2 months ago. You can see that needle reports are centralized in some areas, but they're also decentralized around the city. Saskatchewan has some of the harshest winters in provincial Canada. So we were wondering if the places where people are using and maybe discarding needles would fluctuate in the harsh winters compared to the much nicer summers. And interestingly, there wasn't that much fluctuation. That in general, where people use drugs in the winter is also where they use it in the summer when we split the year into 2 6-month periods. Although when we pretend like Canada still has spring and fall, and we split the year into 4 seasons, we do see a bit more seasonal variation of drug use. And I think this is important to keep in mind if this website was going to be used in other parts of Canada with their own weather, as the changes in weather may lead to changes in drug use patterns. Then we also thought about, since Regina is a non-walkable city, and if you're living rough, you probably don't have a vehicle, so you might be reliant on moderate quality public transportation, or possibly not able to afford bus fare, or the bus doesn't come to your area. You may be relatively confined to a 15-minute walk buffer. And so just with these two maps, here you see APSS and needle reports in a 15-minute walk buffer. And then you see how that buffer expanded as we started pop-ups. So pop-up interventions, especially when they happen with consistency and regularity, do expand the reach of brick and mortar organizations. So for the completed study, we conducted 7 pop-up naloxone trainings, and we saw significantly positive results on the OEND, which is a measure of the knowledge of an opioid overdose and how to administer naloxone. And the support groups were also well enjoyed by participants who found them liberating, as well as healing, to be able to openly discuss drug use without sort of a prescription for abstinence or requirement to stop using, which abstinence-based support groups for drug use are very common in Saskatchewan. As far as we know, our harm reduction support group was the only one available during the time that we offered it. And now Meg is going to talk to us more about our current study, 3 infections, 1 fight.
Awesome. Thank you, Andrew. And I will just have to cue you to change the slides for me. But yeah, I'll be talking us through the 3 infections, 1 fight study that is currently underway, which involves using these hotspot maps from Report Needles to implement targeted pop-up interventions that offer peer-led education, point of care testing for HIV, Hep C, and syphilis, as well as connection to follow-up and/or ongoing care. Next slide. Yeah, so our primary objective is the feasibility and acceptability of these pop-up interventions for people who use drugs in Regina. And our secondary objectives include the preliminary effectiveness of our prevention interventions, so the pop-up testing and the PrEP and PEP education sessions, as well as developing and refining the model so it works well for people and can be adapted or used in other medium-sized cities. Next slide. So we're following a convergent participatory mixed method design, and we are guiding it by the RE-AIM implementation science framework. And again, we have listed our primary outcomes and secondary outcomes. Next slide. So yeah, we have a custom demographics questionnaire that we developed in partnership with APSS just to sort of assess what sort of items or categories we wanted to include. We're measuring feasibility by tracking how many people engage with the pop-ups and how many go on to complete the different pieces of the pop-up. So the testing, the education, the different scales we have, and whether we meet our predefined targets. We're also using the geospatial mapping, so the Report Needles heat maps, to assess reach as well as like hotspot coverage. We're measuring acceptability with adapted items from the SATIS scale, the satisfaction scale, as well as the suitability and acceptability scale. And both of these are specifically being completed by participants at the end of their time at the pop-up. And we've adapted them to specifically assess participants' satisfaction like with our pop-up events. And so where the other scales might be completed, you know, at any point within the pop-up participation, these ones were being very intentional with having them administered at the very end. Next slide. So we are using the INSTI multiplex point of care test to test for HIV and syphilis, as well as the OraQuick for HCV. We're also using a series of subscales that assess participants' like knowledge, behavior, motivation toward PrEP and PEP. And now the knowledge subscale here is being completed twice. So both before and after the peer-led education sessions that are part of the pop-up. And because, again, we're interested in seeing if the education sessions that participants are engaging in impact knowledge with regard to PrEP and PEP. We are also using stigma scale, which looks at experiences of provider stigma, as well as the discrimination scale that looks at experiences of discrimination within healthcare settings. So I will pass, oh, sorry, our sample size. So for the quant component, we are aiming for 300 participants total. For the analytic sample, we're aiming for 210. So this accounts for about a 30% dropout. And for the qualitative component, which I'm realizing now I did not speak to, we're inviting participants back for like follow-up interviews to again sort of assess their experiences at the pop-up to kind of look at the acceptability piece. And so for this aspect, we're aiming for around 30. Now I will pass it to Heather, who will briefly walk us through the sort of procedure that happens at these pop-ups.
Awesome. Thanks so much, Meg. So for our pop-ups to date, from June to November 2025, we've had 9 pop-ups total. We've had 3 indoor and 6 have taken outdoor. For the procedures that we follow for outdoor pop-ups, we have 2 10 by 10 tents. The first tent is sort of a more open tent. That's where we do all of the PEP and PrEP education sessions. Some of the study questionnaires are completed there as well, and more community engagement as well. For the second tent, that's our confidential tent. That is where we sign consent. We pay our participants the honorarium, and point of care testing is done, and the post-scaled questions are done at the very end as well. If a person does test positive on a point of care test, we can also offer them a confirmation blood draw right there on the spot. If a person also tests positive for syphilis and we do correct contact tracing, we're able to offer them their first dose of bicillin right there as well. Next slide. So for our pop-up locations, based on the geographical locations of where we've gone and picked up needles are hotspots. So we're able to partner with different organizations. We worked with existing community partnerships, and we also formed new partnerships with local organizations such as public parks and our local gas stations. 73.6% of our participants reported that the pop-up locations were within a 15-minute walk of where they were living at the time of participation. So I will pass it back off to Meg, and she'll give you some demographics.
Awesome. Thank you, Heather. So yeah, to date, we have 147 unique participants. And what I mean by that is that we don't limit people's engagement with the pop-up intervention. So they can attend multiple times, like multiple different pop-ups. That being said, for the sake of our analyses, we remove these subsequent visits for the sake of comparison, because we can't compare someone's, second or third visit to initial ones. So yeah, with that said, we have had 13 repeat participants. These have been included from our analyses. We've had 16 participants who have been invited back for interviews, 12 have completed them to date, and 1 participant withdrawal. So now I'll walk us through some demographics. Importantly, before I do this, I want to mention that we have quite an extensive demographic questionnaire. So there are many items across each category for participants to endorse. The ones that we're displaying today are the only ones that have been selected so far. So for gender identity, we have had 84 participants identify as men, 61 women, and 2 Two-Spirit. With regard to race, we have 118 Indigenous participants, 23 white, and 6 multiracial. Again, these are the only items that have been endorsed thus far. Next slide. And just a breakdown. So 122 of our participants are Indigenous to Canada, and 22 are not Indigenous to Canada. We've had 109 First Nations, 12 Métis. 2 things to note here. Some of these numbers don't add up to, the total. It's because of missing cases. We also have not had any Inuit participants, likely because there are not that many Inuit in Saskatchewan. Next slide. Yeah, so a breakdown of housing status. Renting has been the most commonly endorsed category, closely followed by unstably housed. Next slide. So here I have sort of a table set up with descriptive statistics of our scales. in our results, the stigma, discrimination, and behavioral skills, which is the like PrEP and PEP behavioral skills scale, have alphas that meet or approach the commonly accepted 0.7 threshold. The status scale is lower at 0.6. And the suitability and acceptability scale at 0.32, as well as the PrEP and PEP motivation scale at 0.41. These fall well below acceptable reliability. And so what I'm going to do now is walk us through some of these scales broken down item by item. So next slide. So starting with the satisfaction scale, items on the scale are ranked between 0 and 4, so from strongly disagree to strongly agree. And what we're finding is that overall participants are quite satisfied. Means are quite high here. The lowest mean, I think, is item 5, which is the length of time spent at the pop-up. So here, it's our lowest mean of 3.37. It's a fine balance, right? Like, we want things to move timely, but of course our priority is confidentiality and privacy. While participants are moving through these different pieces of the pop-up. And so that said, like, staff on site are very transparent with folks about the time spent at pop-up, as well as like working to ensure that people are engaged throughout their time with us. Next slide. So for the suitability and acceptability scale, again, we have some very high means. Items here are ranked from 0 to 5, with most items averaging in the high 4s. Our lowest item, or like our lowest scored item, was item 1, which asks participants about like how well they felt the pop-up was advertised. And so right now, the main way that we are sort of advertising these pop-ups is like community, like kind of word of mouth. So popping up in community, seeing how many people attend, and then sort of one pop-up, we will advertise when the next one is happening. So, we will be mindful of this moving forward. That said, we are finding that across our pop-ups, like, while we do have some repeats, there have been pop-up events that are entirely new participants, so not repeated ones. So word is getting out. Next item. So the stigma scale looks at previous experiences of stigma within like medical settings from providers. Items are scored from 0 to 4, with lower scores reflecting lower levels of experienced or perceived stigma. And we're finding that participants are endorsing like low levels of experienced stigma on behalf of medical providers. So low means throughout. The item that did score the highest was item 9, which reads, like, most medical providers don't understand how difficult it is for me to be a drug user. Next item. So right now I'll move into some of our preliminary findings. So starting with the PrEP and PEP attitude scales, we found that at the time of participation, nearly 96% of our participants had not previously or were not currently taking PrEP, and 97% had not previously or were not currently taking PEP. Next slide. So here we ran a paired samples t-test to assess changes in PrEP and PEP knowledge from pre to post education session. So using that PrEP and PEP knowledge scale. And we found that scores increased significantly from pre to post with a very large effect size. So again, we're having participants complete the PrEP and PEP knowledge subscale. Immediately following will be the education session. And then after that, they're completing the post scale. And so, I'm going to pass it off to Heather now, who will talk through some of the testing data.
Thanks, Meg. So to date, with our testing results for our HIV, we've had 21 people test positive on a point of care test. 2 of those people were repeat participants. Out of those, were able to connect 17 people to follow-up care, and we had 2 people deny being connected to care despite our best efforts. Next slide. So for our hepatitis C, our HCV testing, these ones were kind of our highest. We had 56 people test positive on a point of care. Out of these, though, 35 people did not have an active viral load, so they were a target not detected. We had 3 people refuse confirmation blood work, so we don't know if they have an active viral load or not. We were able to send 8 prescriptions for follow-up treatment. Out of those 8, we had 5 people complete their full course of treatment. 7 participants did refuse any follow-up treatment, and 2 participants were already on treatment at the time that they participated in pop-up. Out of the 5 people that did complete their full course of treatment, we were able to get 1 person with their post-treatment blood work to make sure that they did clear. For syphilis, we had 29 people test positive on a point of care. Out of that, 10 of them had no viral load, so they were a previous positive that went through treatment already. We were able to get 6 participants completed through the full course of treatment. Syphilis treatment's a little bit difficult, so the full course of treatment is 2.4 milligrams of bicillin 1 week, like once weekly, and it's for 3 weeks. So we have to engage somebody for 3 weeks. We had 2 participants complete partial treatment, and then we lost them to follow up. So they received 1 dose at pop-up and never followed up. We had 3 participants refuse treatment. 7 participants were already connected to follow-up care or already receiving their doses from another provider. And we were actually able to connect 1 participant with out of town or out of province follow-up care. For our resources, we have at our table, when you first kind of walk up with our PEP and PrEP education, we have a multitude of different resources. So our maps were created solely for the project. They have safe places for people to go for sexual health, for substance use. There's social assistance, access to community fridges, as well as youth resources. As Meg mentioned, our increase in PEP and PrEP knowledge is substantial, and that is our most taken resource. And although our study is designed for people who use injection drugs, we don't exclude against people who use inhalation drugs. So we do also offer safer smoking supplies to our participants, as well as a pipe pamphlet. And we were able to hand out 71 safer smoking supplies to people. We handed out 457 condoms, as well as 50 dental dams.
Thanks very
I'll
much,
pass
Heather.
it back to Andrew.
Fantastic. So thanks for your attention throughout. We're just about to get to some discussion. I will just mention that on the lab website, we have a community report for the completed Mapping Needles Reducing Harm that summarizes the findings from that study, as well as collates its publications. For Regina specifically, we've created a resource map that geo-locates community organizations that have been deemed safe, inclusive, and person-centered by participants and people representative of our participant population, which are people who use drugs, the majority of whom are Indigenous, and many of whom are unstably housed or kind of living rough. We've also prepared a pamphlet on safer meth pipe preparation, and we have a lot of additional resources on the website. And we spent most of our time today on 3 infections, 1 fight, as we thought it would be of more interest to the network than Mapping Needles Reducing Harm. And I know it was a lot of information. We do have a detailed study protocol published in BMJ Open, which is also available on the lab website. Now we have time for questions and discussion. Thanks again for your attention.